Hello and welcome. Moss Adams is pleased that you've joined us for today's session, Insights into the Evolving Telehealth Compliance Landscape. Before we begin, I'm going to play our housekeeping video.
Welcome and thanks for joining us. Moss Adams webcasts are designed to help elevate your business performance. Transform your future for the better with advisory solutions tailored to your vision and supported by our collective technical resources. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize how you both view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement or enter full screen mode using the controls at the top of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. You can download the group attendance sheet and a PDF copy of today's slides from the slide deck and handouts widget. You can ask our presenter questions during the webcast by typing a question in the Q&A window and clicking Submit. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key. Today's session will offer you 1 CPE credit. To receive credit, you must meet the requirements as specified by the National Association of State Boards of Accountancy. You must attend at least 50 minutes of the session and respond to at least 75% or 3 of the 4 polling questions, which we'll ask throughout today's presentation. Polling questions will appear within the slide window. To participate in the polls, please click on your answer and be sure to hit the Submit button to record your response. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry, if you can't download your CPE certificate today, we'll email a copy to you in 2 weeks. If you're attending this webcast in a group, you must complete our group CPE attendance sheet to receive credit. The attendance sheet is available in our slide deck and handouts widget. Please have all group members sign it and send only 1 sheet per group. Also note that CPE credit only can be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. As a reminder, the presentation you're about to see is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
All right, we have 2 presenters with us today from Moss Adams. We have Melaney Scott, Director, and Kim Hodson, Senior Manager. Their bios and contact information are located in your webcast console. And before we get started, I wanted to acknowledge our big news from Monday, that Moss Adams is joining forces with Baker Tilly to create a new firm, one designed to serve the needs of the middle market. It's really exciting news, and you can read more about it on our website from the link in the handouts window of your console. And now I'll turn it over to Kim to dive into today's topic.
Thank you, Amy, and thanks everyone for joining us today as we talk about the 2025 telehealth landscape. Our plan for today is to provide an update on the current landscape of telehealth services. So we'll talk a little bit about where we're at with the flexibilities and then some important changes that occurred at the beginning of the year. We'll also talk about how to incorporate these things into our compliance work plan. And then we have some case examples to share with you of reviews that we've done where we have found some compliance related items as well. So before we get too far into it, we'll launch our first polling question. So our first polling question is, how are healthcare services currently provided in your organization? All in person, telehealth only, hybrid with more than 50% via telehealth, hybrid with less than 50% via telehealth, or none apply. Okay, we'll wait for just a couple more seconds for folks to answer. I'm kind of expecting this to shake out more in the hybrid with more than 50% via telehealth. I saw a report from HRSA that was indicating that upwards of 96% of providers that have telehealth capabilities utilize it for providing primary care services. And it's been pretty consistent within the last couple of years. So hybrid with less than 50% telehealth. So it looks like we are changing things up a little bit. So let's dive into our telehealth journey. And this comes as no surprise, but in that relatively short period of time, we went from very strict guidelines and limited use case for telehealth to more relaxed in the restrictions and increased need for those services. So during that period of growth, systems were implemented rapidly, perhaps thinking that they would only be used temporarily during the PHE. But now that we've kind of moved past that, we're in this wait and see period where we're waiting to see what flexibilities will be extended, which will be made permanent, or which will expire. There's also been some significant changes to how we report these services, so we'll touch on those as well. So some things that expired at the end of 2024 were first dollar coverage. So that was the part of the CARES Act that allowed us to use first dollar HSA dollars without impacting our HSA contributions. In-home cardiopulmonary rehab services expired. Virtual diabetes prevention programs, which expanded DPP programs to the Medicare population, expired as well. And lastly, the SPEAK Act, which was a task force to improve access for non-English speakers, had also expired at the end of the year. So now with the resolution signed March 15th, we have a little bit of leeway with several flexibilities. And so that includes the originating site. So patient's home remains an eligible site for reporting telehealth services. We still have the waiver in place for geographic restrictions. Audio-only communication remains an option for telehealth services, as well as expanded provider types. So that allows for OT, PT, ST audiologists to provide services via telehealth. The in-person requirements, those are waived for until September. That's the requirement that requires folks to come in for an in-person visit for mental health services. Hospice recertifications can be done via telehealth through the end of September, as well as acute hospital care at home. FQHCs, RHCs, eligible distance site through that as well. Now, through the end of the year, so December 31st, 2025, we're still in the flexibility period for supervision requirements. So that's the ability to be available via audio, video for supervision purposes. Prescribing rules, now these are set to go into effect at the end of the year. They were delayed in part due to aligning with the rest of the telehealth flexibilities. And so beginning January 1, there is an expansion for buprenorphine treatment. And so what these rules will require would be monitoring of the prescription drug monitoring program data for the state that the patient resides in. There's an allowance for a 6-month supply of medication through audio only, after which there's an in-person visit evaluation that's needed. The VA prescribing rule will go into effect as well, and this permanently allows veterans to receive their controlled substances through telehealth visits, as long as they have previously seen a VA provider. Some other rules and regulations that the DEA is considering are around special registrations. So these are advanced telemedicine prescribing registration, where you would sign up to be able to dispense or prescribe Schedule II medications. So more to come on that. Some things that have been made permanent. Now, these have been permanent since the end of 2023. Medicare patients can receive services for behavioral mental health care within their home. There are no geographic restrictions for those services, and they can be delivered via audio only. So what's new for 2025? There's been some significant changes in coding, particularly for 2025 that impact telehealth. So I'm going to talk through those pretty quickly. But first, I believe we have another polling question. So as we start to think about risks and how we're going to incorporate those into our compliance programs, what do you think the biggest risk is in delivering telehealth? Probably at this stage in the game. Is it related to documentation, coding changes? I mentioned there were significant changes at the beginning of the year related to telehealth. Vendor compliance, so not just with other areas of the organization that we use vendors, but specifically with telehealth. Incident to requirements, something that has been on and off and then on again with the OIG. Other, and then maybe not sure. So we'll wait just a couple seconds. It looks like we have 68% in. So we picked these intentionally because towards the end of our presentation, our case studies will discuss each of these topic areas.
All right, before I do the results real quick, I do just want to point out that some people are having difficulties finding the polling questions. They are located right on the slides that we're presenting. So if you do not see it, you might need to hit F5 to refresh your console, and then make sure to hit submit.
Thanks, Amy. Okay, so Ty, documentation and coding. Yeah, those two things go hand in hand. So if your documentation has problems, your coding is going to have problems as well. So we have some case examples. We'll talk through both of those where I would agree that those tend to be some of the bigger issues related to telehealth. So what's new for 2025? And we talk about this because it's an update, but it's also something that gets us thinking about how we're going to not only implement new codes, new services, but how we're going to audit and monitor them and where we're going to put them within our compliance program. So with the 2025 physician fee schedule, there were some additions to the Medicare telehealth services list. Now, these are provisional service coverages. These are provisional coverages, so CMS is still working out how to pay for these services. But it includes something that is relatively major. It's caregiver training. So they've created these codes, G05, 39, and 40, to cover instances where a provider is training a caregiver. So that's limited to a family member or another designated adult that will be assisting in care around specific topics: ulcers, wound care, infection control, and behavior management and modification. So if this is a service that you're thinking about providing, CMS has done a great job. They have a 15-page guide, including FAQs on this particular topic alone. It's worth a read, particularly when they talk about documentation that's required. So. Also included in the 2025 physician fee schedule is PrEP counseling. So these are codes G0011 and 13. These services can be provided by telehealth, and the code that you select depends on who delivers the counseling. So is it the physician or qualified health practitioner, or is it by the clinical staff? And it also includes a time component to it. So for example, here, when a provider delivers that counseling, there's a 15 to 30 minute time component associated with that. Anytime we have time components as a requirement to a code, it's a good idea to think about how we're going to monitor to make sure that the time is met, and then how we're going to support that time being met. And we'll cover that in one of our cases too. Some deleted codes for 2025 include telephone service codes. This is something that wasn't always, it wasn't reported very frequently, especially this G2012 code. And when it was reported, it probably wasn't reported correctly. So they were deleted, and in its place, there were new codes that were included in 2025. And 17. So there's a lot of new codes that cover telehealth services. They went into effect January 1st. The structure mirrors the traditional evaluation and management structure. So that means you're selecting a level of service based on the total time or the medical decision making. And the difference between the coding groups is that one is for audio-visual services. The second group is for audio only. And within each of those categories, there are new and established patient codes. The one thing I do want to point out that for me is, I think about it from a compliance perspective as being significant, is that under the audio only E&M range, this third bullet here, which is medical decision time threshold of 10 minutes. So this is different than what we typically see. Typically, we see a time threshold of at least X number of minutes need to be documented to report a code. In this particular case, 10 minutes of that visit have to be dedicated to medical decision making time. So it's a change in how we typically see things documented. It'll be important to provide training to the providers and clinicians around documentation to support not only medical decision-making time, but also total time of the encounter. Continuing with our group of codes added for 2025 are the brief synchronous communication codes 98016. I mentioned that CMS deleted the G code that basically reflects the same service. They will cover the 98016 code. Again, there's a time threshold component associated with it. Now, CMS won't cover any of the telehealth codes that we just talked about, but for the 98016. Instead, they want these services reported with the traditional E&M codes, the 99212 through 5, with the appropriate modifier and place of service. So that kind of brings us up to current, where we have been within the last couple of months. And now we're going to shift gears a little bit and start to talk about how to incorporate all of these things into our compliance work plan. So at this point, I'll turn it over to Melaney to dive into that piece.
Wonderful. Thank you, Kim. Good morning or afternoon, everyone, depending on where you're hailing from this morning. So thinking about we're going to start with kind of a macro discussion and get ourselves down into the micro, thinking about specific to telehealth, but really wanting to start with thinking about why is a risk assessment important, which feeds into our work plans, of course. Well, we have here a slew of different federal regulators, federal agencies, and usually definitely multiple apply to an organization. But wanted to call out when we think about two specific things, maybe three actually. Office of Inspector General, DOJ, if for some reason they are coming to an organization, those are elements that they're going to be looking at in consideration of how effective is our compliance program. And this also could play worst case scenarios into their consideration along the US sentencing guidelines, along that spirit of effective compliance programs as well, and what outcomes could be. Another really important component of this, when I think about this at an organizational level, is in our healthcare environment and the board responsibilities for governance. Risk assessments are a very effective tool to help when we're reporting up through the board, to help them understand the mechanisms of the organization and how risks are being responded to as well. Which does bring us to our third polling question related to when you think about your organization and the risk assessment process, what does that look like? So A is that there's an entity-wide risk assessment conducted annually, meaning several groups or all groups get together and discuss those risks and come up with kind of entity-wide assessment of that. Is that same entity-wide process every 2 years? Or does each department do their own risk assessment, identify their own work plan items, and everybody just kind of goes about their ways? Or if we think about it, maybe this is the first time we're touching on, you're hearing about a risk assessment. So really, what is that? Or I'm not sure how that functions at our organization. And we're getting close. We got about 63% of folks who have responded so far. Want to give time for everyone who is able to respond. Because again, to get our CPE, we want to make sure we have 3 of these 4 polling questions responded to. We're getting closer, everyone. Thank you so much, Amy. So what we have here, which is really good, entity-wide risk assessments are conducted annually, which is wonderful. And I think when we're also thinking about this, an ongoing process as well to consider what risks might be emerging as well that we need to consider for our organization. So really when we think about from the process of this risk assessment, because nobody has the time to address all risks, nor does it make sense in an organization to take a look at every single risk we have. But risk assessments will give us that opportunity to assess and prioritize the identified risks. And most oftentimes we all start with some level of a risk universe. And sometimes we get the question, well, how many risks should be on our risk universe? And I have seen some organizations that just kind of blew my mind away, that they had like 1,000 or more risks on their universe. I think that's a lot. It might be a little bit micro level, but again, very organizational specific. Usually we see it hovering around in the hundreds on there. But with our universe, and then thinking about that way to identify what really should we be looking at as an organization, is this process to assess and prioritize the risks. We often recommend considering this from a twofold perspective. One is the likelihood that something's going to occur from an adverse perspective, as well as what could that magnitude be for our organization. Sometimes we might see magnitude referred to as impact, consequence as well. And then really getting us to a method to rank what these risks are based upon that convergence of the likelihood and magnitude or impact as well. And this here, what we have found is some sort of quantifiable method to provide to folks, usually organizations. Some will do a survey out to varying stakeholders in the organization. Other times there could be one-on-one meetings or group sessions as well. But something along this is just an example of a method to be able to provide a consistent method for considering the likelihood and magnitude of a particular risk. We often will use the 1 to 5 scale, but giving some quantification to each of those. And that really helps. Oftentimes when we're talking with folks, we'll just also ask them, think about this and give an overall rating of that 1 to 5 scale as well. And really at the end of the day, by using some level of a scale, thinking about that likelihood and magnitude, that helps us to prioritize, like we mentioned, of what we've got for our risk landscape. And we often would recommend going a little bit of an extra step, and that is having discussions with process or risk owners around these kind of higher level risks that are at least initially identified, to identify and solicit what sorts of controls, or what usually we frame it as, what are the activities occurring around this risk to help mitigate that risk. And when we think about from a control structure, we've got some examples here. Policies and procedures are probably one of our best baseline controls in place. It outlines management's expectations for how things are intended to occur. Education and training as well. When we think about audits, that could be within a department, and what I call like self-audits that are occurring. Monitoring is another example. So exception reports, if you have a cadence of a particular area where you're getting data reports of that, so you can monitor for trends and other pieces. If there's quality assessment processes in place around those, as well as management review and approval for certain things. Work queues is another really big potential control we have as well. And there's lots of others, but this is just to spur on ideas. And like we mentioned, when we are thinking about discussing particular risks with with risk or process owners, interesting things can come out of that discussion that can also help inform us as far as the potential timing to look at something. For example, it's been many times where we are discussing a risk and it's identified or noted that there is going to be a new system conversion or something similar that is expected to have some significant changes to a process. Well, we may not want to go in right away and take a look. It also could frame how we want to take a look at something. So really great information can come that helps inform us of our work plan and the timing of accomplishing things that are on our work plan as well. And wanted to take a quick moment to discuss the difference between auditing and monitoring. We hear those terms a lot, and really when we think about auditing, is this more formal and systematic approach to a particular risk topic that's looking at evaluating controls, processes, and we'll look at a period of time in the past. So as an example, it could be looking at the prior quarter, prior 6 months, prior year. It's also really wants to be done independently. To be, I think when we're thinking about this, there's lots of auditing that goes on in departments of their own work, but really encourage us to think about what are the independent audits that are happening either through our second or third line of an organization, meaning compliance or risk departments or internal audit, versus when we think about for monitoring is more real live information coming. So again, that could be exception reports that could happen on a daily basis or some other cadence, work queues where things might pop into to show up, data analytics, where it is on, again, a recurring cadence. Information is coming, so it is very much more real time that we can get information to make action on if needed. Wanting to touch real quick here, not going to spend a lot of time, but just some things to think about for conducting an audit. And a couple highlighted items with this is when we're thinking about starting out for a particular audit, really identifying what the scope and objective is going to be. Sometimes we have a topic that could be pretty broad in nature. However, we might want to have a more narrow scope depending on what we have identified, meaning just very specific in what we're going to look at. Other times it might make sense to combine a few things into our sample that we might be looking at. Really thinking about the proper criteria, which also is referred to here as materials. So what really are we going to be looking at and gauging what we're testing on? Is that going to be specific policies, procedures within the organization, or specific laws, rules, regulations as well? I would also say determining the sample size. I see a lot of questions that often come up in what really is our correct sample size. Depending on the audit, there's a couple different resources that we've looked to and are available out and about. Again, oftentimes for certain types of audits we're doing, I look to the AICPA sampling guide. It has both ideas for a substantive sample, a controls only sample, as well as compliance. So sometimes that can help provide us with ideas. Again, there's lots of other ways, and the nature of the audit will help predict or help dictate what we want to look at. I think when we think about getting down to the report component, couple things we often see that we provide feedback on with this is really findings and or observations, as well as what are the recommendations around that. A lot of times it's thinking about what was getting to that root cause, so to speak, of whatever we found, whatever the finding was, and corrective action plans that directly tie to the recommendations and what was found. Follow through is a really big piece of this that also will feed into our effective compliance program. And that is, what is our process for following up on these corrective action plans or management action plans? Touch bases with whomever is the action owner, following that through to resolution and having that all documented is a super important piece that we do see lots of opportunity at organizations for shoring up, as well as whatever ongoing monitoring might be. And I would say, depending on what we find with different internal audits that occur, that could also help us identify if there are emerging risks, or if we need to make an adjustment to our work plan as well, if we're seeing some significant outcomes from audits. Okay, that does bring us to our fourth polling question of the morning, which is thinking about, do you have on your particular work plan, do you have telehealth included on your audit and monitoring work plan? So yes, we do, actually, for 2025. Not yet, but we're planning to have some sort of a topic in 2026. We think we probably should, but we're just trying to figure out how to go about what would be the right topic to get for C. D, we're not sure if it's included within our organization. Or E, it's not applicable to our organization. And I was going to take a look to see, it looks like we might have had a couple questions coming in. I was looking to see if there were any that are fairly innocuous to discuss. You guys have great questions. I think some of them are pretty in-depth as well. But I don't know, Kim, are you able to see the polling status? It's not shown up on my side. Oh, there we go. Spoke too soon. So yes, it looks like a lot of us have it on our plan in 2025. Wish we could have just a discussion about that, like a little roundtable to see how and why that came about for you all. It looks like also we're just about tied between not sure if it is or it's not applicable to you all. So totally understand. And I think with that, Kim is going to delve us into some of these specifics of around telehealth from a micro perspective on work plans.
Yes, thanks, Melaney. So where do we see telehealth services show up in work plans? So what are people looking at in 2025? Couple of the more prominent elements are listed here on the slide. So location of the provider that's delivering the service. Is the provider within the United States? Are they overseas delivering the service? And how do you go about monitoring that services are not provided outside of the United States? Oversight of services and incident too. So this goes back to your supervision requirements and plans of treatment. We'll talk about that here in a moment. Updates to monitoring activities. So where we were monitoring services, 2 years ago, does it make sense to continue to monitor in the same way? Or do we need to incorporate some other elements? And we'll talk a little bit about where the OIG is looking to. Of course, I feel like it's just going to be forever preparing for the end of flexibilities because, as soon as we get ready for it, it seems like it gets kicked down the road a little bit. So, but continue to have the end in mind. What does that look like for your practice? Updating policies and procedures and incorporating telehealth into training and education. So let's talk through some specific case examples. And the way I have the slides set up is the information on the left-hand side is from an OIG report. And the cases that we'll talk about they're not the same cases, but they're related in terms of risk. So one of the areas that the OIG has been looking at and performing some data analysis around is on Medicare and Medicare Advantage claims for telehealth services. So they've identified 7 risk areas that they believe represent a high risk of fraud, waste, and abuse. This is really around how you line up according to your peers. So are services being reported at the highest, most expensive level? Are there a high average number of hours reported per service? So the OIG mentions 2 hours or more of telehealth services per visit would be considered an outlier. A high number of days per year, a high number of patients, telehealth services for a high proportion of the services. So your visits sway more towards telehealth than your peers do. Combination of providing telehealth services and prescribing DME, and then billing for both the professional and facility fee. So we already see the OIG looking at groups and some of the enforcement actions that are coming out of that. So our particular case study here is looking at telehealth services, and at the time they're reported with your traditional E&M codes. And so our blue line is what was actually reported by our group. And the orange line represents what Medicare's averages are. So utilization is available. It's pretty easily findable, and it's generally can be specific towards your specialty. With the exception of behavioral health, that one's a little bit trickier to find, but it's still out there. So what you can do is you can plug in your numbers, so how many 99205s you've reported for the year, and kind of run that model against what your peers look at. We did this type of work a lot when EHRs were first implemented, and we saw some patterns change within our coding. It's good practice to do this exercise again, focusing on your telehealth services. So given this example, you can probably guess at where we're going to look. There's some glaring issues here. For our new patients, we are way out of range with our high-level 99205s, and we haven't reported anything in the lower, the lower ranges. For our established patients, we're in range within the 4s, but there's definitely something going on the bookends of that. So this is the data that we're looking at, and so we build our audit around that. So does the documentation support that level by either total time or by medical decision making? And in this particular case, we're looking at the modifiers associated with the E&M service that helps differentiate them from other E&M services. So we took a look at the sample. We selected a statistically valid sample, and of the ones we looked at, 40% did not meet. And so we start to think about why they didn't meet. And it comes down to basically changes within E&M over the last couple of years. So the requirements for selecting a level of service have changed, and the times associated with those services have changed as well. So I'm sure, you know, when that happened, the training we provided to our providers may or may not have stuck. We had a very long history of doing things a certain way, and to have it change is tough. So looking at why the time and medical decision making didn't support, there's a couple things to consider. One of those being, you know, did we provide training on the changes? Another is there a system issue that's contributing to the changes? And so in this particular case, the actual EHR was not updated to include the new time descriptions associated with the E&M. So it had 99213 old time instead of 99213 new time. So when you're in the moment and you're assigning codes for your service, you're either picking by memory or you're looking at descriptions. And if those two things aren't aligned, you're going to select the wrong level of service. So some solutions were to implement a work queue for those high-level E&Ms so they could be reviewed prior to billing. Of course, the system is going to be updated and will provide some re-education. So let's talk about documentation deficiencies. So we have an example here where some deficiencies caused some issues with the risk adjustment diagnoses, overpayment. When we think about telehealth, other things to consider around documentation are around consent. In telehealth, that consent really is it lays out the benefits of having a telehealth services. It also talks about the risks associated with it. It typically needs to be written and signed or at least acknowledged in a way within the patient's chart. I will say there are state requirements, so make sure that you've looked at your state requirements for consent and that you've ensured that your system supports those. Documentation needs to support the service. So where is the patient located? Where's the provider located? Are there other individuals that are involved or participating in that encounter? All of that should be documented. Time or start and stop time for those services. So here is where I'll make a suggestion that start and stop time is best practice. Not all states require start and stop time for encounters. It can be total time. but start and stop time is a little more comprehensive and covers more, especially if you're in multiple states. The modality, so was it delivered audio, visual, and is the diagnosis code supported? Telehealth service needs to be above and beyond a virtual check-in. So let's take a look at this particular case. So here we're looking to see if the telehealth services are documented according to, I'll say, federal and state requirements. So as I mentioned, states do have specific requirements around things like consent and start and stop time. So we're going to look at that documentation to make sure that those things have been captured. So our audit inquiry here is on the left. Our findings were that about half did not meet, primarily related to the consent. And so this is an area where I think it presents a risk for telehealth services is around consent. Perhaps we got a verbal consent at the beginning of the PHE, and we haven't updated it, or our practice has been open and we haven't gotten a written consent to provide telehealth services. So it's an opportunity to kind of look at the process and make sure that you're having a checkpoint either at that next in-person visit, or that there's some form of record review on an occurring basis for consents. Additional issues that we found were around minimum time for the service not being met. So again, this goes back to documentation of time, and that's reflected in the note. Corrective actions, things that we put into place were, I mentioned the process around obtaining the consent. Of course, education and training is with any thing that we're trying to correct, and monitoring of consents. So if you have an individual that hasn't been seen in a while, we have a pre-record review that's checking for consent. If one has not been signed, or one that hasn't been updated in a while, that's being flagged. So we're getting that at time of service. Another kind of hot topic here is around therapy documentation. I meant behavioral health therapy, mental health therapy, but some of these same things apply to your physical therapy setting. The example here that I have is a recent one where the OIG found that telehealth psychotherapy sessions didn't meet the time requirement. So just a word of reminder, under 16 minutes is something that is not billable. Again, I would just reiterate that start and stop times are ideal in these situations. If an evaluation and management service is provided in addition to therapy, those services have to be supported. We find a lot of times that E&M and therapy services are not different from each other. Checking for treatment plans, making sure that those are complete, include the type, the amount, the frequency, duration of treatment, what we're treating the individual for, what we expect their progress to be. Needs to be signed by a recognized provider. This is another area of deficiency. We see everything from staff signing therapy plans, staff signing records, to situations where there could be an oversight arrangement, but it's not documented appropriately. If we're doing it by telehealth, the telehealth services are supported, so we're looking to that other set of documentation to support that. And if it is delivered as an incident to service, that is supported as well. So taking a look at our case study here, we're again looking to see if the therapy services are documented. Our audit inquiry there is on the left. 12% of the ones we looked at didn't meet, primarily due to the time requirement. I mentioned that there are state requirements. I can't stress it enough to make sure that you know what those are. Treatment plan deficiencies, so this included things like missing the modality and treatment progress to just not having a treatment plan that was signed, and full signature, including credentials. That's important. It's more important when you have an external review that information is there. So what did we do after we found these things? In addition to education and training, the therapy notes were evaluated, and where we could, we put some hard stops in where elements had to be documented before you could move on within the record. Revised the documentation template to include start and stop time. And again, we're going to monitor those services going forward. Incident 2, this one is just, it has its moments, and it's having a moment again. So it was added again to the OIG work plan, and we have an example here of late last year where we had some incident 2 supervisions that were not met for this particular urology clinic. If you have incident 2 services, this should be on your work plan, no doubt, because it's just being looked at. And I'll show you our case here in a second. They're just often not supported in the ones that we've looked at. So again, we're looking for what is the oversight and supervision. Now, incident 2 supervision is not the same as a supervision requirement that's needed for clinical reasons. So a PA is still within their hours where they need clinical oversight. That's not the same as billing a service incident 2. It also has to be driven by the physician's treatment plan. So is there a documented treatment plan that we're referring to during those subsequent services? Provider needs to see the patient at a frequency that reflects that involvement, and billing needs to meet payer guidance. Not every payer acknowledges incident 2 the same way that CMS does. So here's our case study where we really took a look at the incident 2 services. So how this was identified is a report that was ran from the system that included a lot of things, but 2 basic fields: the rendering provider and the billing provider. And based on that, if those 2 were different, we would anticipate some kind of incident 2 supervision kind of situation. So selecting a sample of those and taking a look at the incident 2 requirements. With that, we found that a significant portion were not met, and for a variety of reasons, but I think it boils down to two main things. One is there is a distinction between clinical supervision requirements and billing requirements under incident 2. They're 2 separate things. And the documentation doesn't always reflect that it's a separate thing. So for instance, in this case, the provider, the MD, was co-signing or signing off on the notes that were drafted or that were prepared by their nurse practitioner. From a clinical supervision perspective, that's absolutely fine. But what was happening is that was getting translated into a billing service. So now the MD was the billing provider on that record. So that shouldn't have happened. Part of it was a system issue that was causing it. So in order to access that NP's record, the MD has to go into that note and type in it. So the system was recognizing 2 individuals and was reporting it out under the MD as the billing provider. So a system issue was partly to blame for driving that change. Other things super common: changes to treatment plan. So patient may be coming in for a incident to service, just a regular follow-up, and something new is brought up, or there's a significant change to the existing plan. In those circumstances, those are billed under the NP and not the MD because there's been a change. So the last one we'll talk through today is around vendor compliance. So it's not only vendors related to security, which of course is super important, but it's also vendors that may impact your telehealth practice. I have it's not really a quote, but it's a sample from the DOJ guidance that was updated in September, where they expect that third-party management is something that's on your compliance program, and that evaluating vendor compliance is a way to demonstrate your ability to detect and prevent fraud and misconduct. So these are the things we're looking for. How do you identify risk? What controls are in place? How is the relationship managed? Do you have the right to audit? What happens if there is a finding? What options do you have there? So again, audit inquiry here on the left. This particular case, we're looking at remote patient monitoring, the vendor software, and whether or not it met the requirements needed to support remote patient monitoring. And in the evaluation of the software, we found that it didn't meet it in all cases, and primarily due to the fact that it wasn't capturing the portion where the provider was making notes. So every month they have to make a note, and that information was getting dropped off. In discussions with the vendor, we found that the vendor had, I'll call it a paper program. They downloaded some policies, procedures, and that was their compliance program. So they didn't really have a way to monitor themselves to make sure that they were compliant. And so, some mitigating actions had to be deployed because of that. Of course, we met with the vendor, encouraged them on their compliance program, make sure that it's specific to them and that they have ways to monitor to make sure that they are compliant. And in order to support those services, the provider had to really document some of those missing components on their own. Other things you can do when working with vendors is review your BAA agreements, complete a vendor risk assessment. So Melaney talked about the risk assessment process, tailor that to the vendors so you can identify which of them might represent a higher risk. Again, security assessments, compliance program evaluation. This is one that I don't see done very often, but it's super important. I have found that working with some vendors, they don't have a compliance program of their own. And when asked, they rely on the fact that they've completed a SOC assessment or they have a high-tech assessment. So we're looking for other things from a 7 elements perspective. If you have a vendor that is doing any marketing or solicitation on your behalf, make sure that you're reviewing that information that they're providing. So I would say, as a wrap up, I think we're all kind of in the same boat. We're just going to wait and see what happens with the telehealth flexibilities. We have a few months before we start panicking again. So now's a good time to take a look at your program, see what risks you do have. We've provided some ways to look at those risks and some things that you can consider doing should you have similar concerns. And then, we'll keep tabs on the DEA since those things tend to coincide with each other. So at this point, I'll turn it over to Amy. Thank you all for your time today.
All right. Well, thank you, Kim and Melaney, for a great presentation today. I also want to thank our audience for being engaged and submitting all your questions to help guide our conversation. If you have any further questions or comments, please reach out to us and we would be happy to continue the conversation. You can drop a note in the Q&A window or reach out to our presenters directly. Their contact information is in your console as well as in the slide deck, which you can download now from the handouts window. And we invite you to visit our website for more resources and information on this topic, many of which are linked in your console. And then if you met all CPE requirements, your certificate is available to download now in the CPE progress window. A copy will be emailed within 2 weeks as well. And finally, here's a link to a survey for today's presentation. Your feedback is always appreciated. And again, thank you for joining us and take care, everyone.